Welcome. Today's class is on Milan reporting system for salivary gland cytopathology. Milan reporting system for salivary gland cytopathology was proposed by International Consortium of Experts, American Society of Cytopathology, International Academy of Cytology. The main aim of this particular system is to standardize reporting terminologies, which helps in replacing the conventional descriptive interpretation for salivary gland FNAs that is useful for better communication between a pathologist and a surgeon, also for better communication between the institutions. The main outputs useful for clinical decisions and laboratory quality control are risk of malignancy, that is risk stratification, and frequency of each diagnostic category. So this can be got by the help of this categorization, risk of malignancy as well as frequency of each diagnostic category. So according to Milan system, there are 6 diagnostic categories. First one is non-diagnostic, second one non-neoplastic, third one atypia of undetermined significance, fourth one neoplasm. Under 4 there are 2 subcategories, 4A and 4B. 4A is benign, 4B is sump. Sump is nothing but salivary gland neoplasm of uncertain malignant potential. Fifth category is suspicious for malignancy, and last one is malignant. So this is a very important table. I have put it in the beginning because to know the risk of malignancy. Here risk stratification is done based on the diagnostic categories. So first we can see that the maximum risk of malignancy, ROM, is nothing but risk of malignancy, that is 90%. It is seen for the last category, that is malignant category. Next highest is for the 5th category, that is 60% risk, suspicious for malignancy. Also we should see that there are 3 other categories which are important here. One is non-diagnostic, another is atypia of undetermined significance, and one more is sump. Because if we observe the risk of malignancy in these categories, in case of non-diagnostic it is 25%, in case of atypia of undetermined significance it is 10 to 35%, almost 20% average we can take, and in case of sump it is 35%. So if we report it as if we report under these 3 categories, then the risk of malignancy is also more. So we should be careful because it is helpful in the management of the patient. Once we put under these 3 categories, then the managements for all these 3 will be different. So if we put it as non-diagnostic, then it is definitely wise to ask for repeat FNAC, maybe ultrasound guided FNAC after few days with clinical and radiological correlation. If we classify it under atypia of undetermined significance, definitely we can ask repeat FNA, maybe ultrasound guided FNA, or surgery. Before going to surgery, core needle biopsy can be asked, and after that it can be planned for surgery. If we report it as sump, again surgery is a mainstay they are telling, because here the risk of malignancy is 35%. So based on this risk stratification, the management of the patient will be carried out. So this is really important to categorize them properly under these 6 categories. Okay, what are the diagnostic criteria? So first one is non-diagnostic. First category is non-diagnostic. To call it as non-diagnostic, what are the criteria? Insufficient cellular material. So the cellular material should be insufficient. So they are considering it as less than 60 cells for cytological diagnostics. If microscopically we are seeing less than 60 lesional cells, then we will put it under first category, that is non-diagnostic. Next one is clinically they are telling there is some nodule, but microscopically we are just seeing some non-neoplastic normal acinar cells. Then again it will fall under first category, that is non-diagnostic category. Then if we are finding only non-mucinous cyst fluid in the slide, that is we are finding some cyst macrophages in the slide and the fluid, it is non-mucinous, okay, just non-mucinous cyst fluid is there, that time again it falls under category 1. If at all this non-mucinous fluid, that is the cyst macrophages, are accompanied by some atypical epithelial cells, then it will definitely go to category 3. But just non-mucinous cyst fluid, then it will fall to category 1. Here we have to consider one more thing. What about mucinous cyst fluid? Whenever mucin is present, it is dangerous, because you know mucin is present in mucoepidermoid carcinoma and all. So that time, if at all mucin is present, mucinous fluid is present, it will be put to category 3. So presence of mucin or non-mucinous cyst fluid, that is really important here. Next, poorly prepared slides with artifacts. So we know different types of artifacts like air drying artifact, blood which will be obscuring the slides, or poor staining, all these things. So if at all these things are there, then again we can put under category 1. So this is a diagnostic criteria for category 1, which we can consider it as non-diagnostic. We know this category is really important because risk of malignancy here was 25%. So further, after few days we can repeat the FNA under ultrasound, or we can go for core needle biopsy or open biopsies. Then we can see what exactly it is. Next category is category 2. It's a clear-cut category, that is non-neoplastic category. All the benign non-neoplastic conditions, benign non-neoplastic conditions like infections and inflammations and reactive conditions, everything fall under this particular category, that is category 2. So here sialadenitis, sialolithiasis, granulomatous inflammation, infection, reactive lymph node, all these diagnoses will fall under category 2, that is non-neoplastic category. Coming to the third category, this is a really important category, that is the third category, that is atypia of undetermined significance. So what is the criteria for this atypia of undetermined significance? First one is limited cellular atypia, that is atypia is there, but that is not enough to call it as a malignancy. So that is limited cellular atypia. Qualitative and quantitative features are lacking for diagnosing a neoplasm here. So that is again it falls under category 3. So what are the common AUS conditions? One is reactive, regenerative, reparative atypia. Another metaplastic changes. Example, oncocytic metaplasia, squamous metaplasia, but they are not definite to tell it as a neoplasm. We know squamous metaplasias and oncocytic changes, squamous changes, everything will be seen in certain malignancies of salivary gland, but they are not definite to tell it as a neoplasm. Just metaplasia is there, then we can put it under category 3. Mucinous cystic lesions with an absent or very limited epithelial component. I told previously itself, if it is mucinous cystic lesions, definitely it will go to category 3. If it is non-mucinous without any epithelial component, will go to category 1. Non-mucinous with atypical epithelial component will come to category 3. Low cellularity FNA suggestive but not diagnostic of a neoplasm. Again we can put under category 3. Lymphoid lesions, indefinite for lymphoproliferative disorder. Again it comes under category 3. So all these conditions can be considered under category 3. And as you know, for category 3 we have to definitely repeat the FNA after few days, maybe under ultrasound guidance, or we can go for, or the surgery will be considered. Next, coming to category 4. So category 4 has two subdivisions. One is benign, another is sump. So category 4A is benign. Straight away the benign lesions, or benign neoplasms, not the benign lesions, benign neoplasms of the salivary gland. They can be divided into epithelial neoplasms, mesenchymal neoplasms. Under epithelial we know the commonest pleomorphic adenoma, then comes Warthin's tumor, oncocytomas. Mesenchymal neoplasms, schwannoma, lipoma, hemangioma, all the benign tumors, they fall under this category. It's a clear-cut thing. So if surgery is required, they'll go for surgery. Sometimes clinical follow-up will be just enough, but some definitely otherwise they will go for surgery. Next, coming to very important category, that is sump. Because if at all something falls to this category, or if we give report under this category, then they will plan for surgery, because here the risk of malignancy is 35% for this particular category. So here under sump, cytomorphological features, diagnostic of a neoplasm but indefinite for a specific tumor type to further distinguish between benign or malignant. Here we cannot tell the features are whether benign or of whether benign tumors or whether they are of malignant tumors. The confusion lies between benign and malignancy. Those lesions or those lesions can be considered under category 4B, that is sump. So under sump, so common sump conditions are three. Very important, three conditions are there morphologically. One is cellular neoplasm with basaloid features. Here pleomorphic adenoma, basal cell adenoma, these are all having the basaloid features, but we cannot clear cut tell that they are these tumors. That time we can just tell cellular neoplasm with basaloid features and we can put it under category 4B. Next, cellular neoplasm with oncocytoid features. We know these features come under tumor, Warthin's tumor, oncocytomas. Here those features are present, and cellularity is also too much. To tell it as benign, it is problematic because of some features. To tell it as malignant, it is problematic because of some features. So when it lies between that, then we can put it under category 4B. Cellular neoplasm with clear cell features. That is examples: myoepithelioma, epithelial myoepithelial carcinoma, mucoepidermoid carcinoma, all these things come related to this. But we cannot clearly tell whether it is benign or malignant. So better to put it under cellular neoplasm with clear cell features. So three morphological subtypes are there under sump, that is cellular neoplasm with basaloid features, cellular neoplasm with oncocytoid features, cellular neoplasm with clear cell features. Then other low grade carcinomas also can be considered here, and because since the management for this is surgery, so that should not be a problem. So next category is category 5, that is suspicious of malignancy. Here features that are highly suggestive of but not unequivocal for malignancy, but it will not go with the malignancy. Almost all the features are there but not completely there. It is like that. So common suspicious for malignancy conditions: markedly atypical cells with poor preparation or obscuring factors. You're finding atypical cells, they are there, but something is obscuring them. Maybe a blood or proper staining is not there, some drying artifact is there. So that time we can put it under suspicious. So limited cytological feature of specific malignancy. Example, we know in adenoid cystic, you are having cellular atypia with hyaline globules. They are there, but they are not enough to call it as adenoid cystic carcinoma. Mucoepidermoid, in that mucin should be there, mucous cell should be there, extracellular mucin, everything is there, but they are not enough to call it as mucoepidermoid. In case of secretory carcinoma, cytoplasmic vacuolation is there, it is not enough to call it a secretory carcinoma. So such when limited features are there, again it will go to category 5. Next, suspicious cytological features in the subset of cells but admixed with predominant benign features. Here we can consider pleomorphic adenoma, where benign features of pleomorphic adenoma is there, along with some subsets are showing cytological atypia and all those things. That is carcinoma ex pleomorphic adenoma, that can be considered under this particular category. Next, two lymphoid lesions are there. One is monomorphic population of small lymphocytes suspicious for low grade lymphoma. Another scant large atypical lymphocytes suspicious for high grade lymphoma or Hodgkin's lymphoma. These two lymphoid lesions also, if they are suspicious, they can be considered under category 5. Here the risk of malignancy is more, that is 60%. Again, surgery will be considered in this particular category. So before going for surgery, again core needle biopsy, open biopsies can be preferred with some ancillary tests like immunohistochemistry, molecular testing, everything is preferred, and after that they'll be planning for surgery. Next, coming to the last category, the sixth category, that is malignant. Here FNAC will show the diagnostic features of malignancy, clear cut, and attempt whenever it is in this category you should be very careful. We have to grade it, which type, whether it is low grade malignancy, intermediate or indeterminate grade, then or the high grade. So that is important here. Grading becomes important. That can be given by us, by the pathologist. And next, along with that, typing if possible. What is a type of malignancy? Whether it is SNX cell carcinoma, whether it is salivary duct carcinoma, whether it is mucoepidermoid carcinoma, that typing should be done. So that will complete the sixth category, that is malignant. So low grade malignancies of salivary gland, that is SNX cell carcinoma, secretory carcinoma. High grade salivary duct carcinoma, lymphoepithelial carcinoma. And intermediate, that is with multiple grades, that is mucoepidermoid carcinoma, adenoid cystic carcinoma, and other malignancies of salivary gland like lymphoma, sarcoma, metastasis, everything will be considered under category malignant. So here we know the risk is 90% and surgery will be the mainstay of treatment. So this was with respect to 6 categories of Milan system. Next we will see the meta-analysis table for all the 6 categories. So here first criteria here is percentage, that is frequency of each diagnostic category, which was common in the study, which was common. So common was a benign category, that is 30 to 40% of lesions was falling under category 4A, that is neoplasm, which are benign. Example, pleomorphic adenoma, Warthin's tumor, oncocytoma, all those things. Next, estimated risk of malignancy. So this is already discussed, which is more for malignant, and we have to be careful about 3 categories, that is non-diagnostic first category, third ATP of undetermined significance, and SUMP. Next, real world risk of malignancy, that was estimated risk, that theoretically real world risk also almost okay, but in the real world ATP of undetermined significance and SUMP, so risks are more here. Non-diagnostic is having the least risk, because usually due to some other factors it would have been like non-diagnostic category, but in the real world the risk is less for this category, but it is more for again third category and 4B category, SUMP category, definitely maximum for malignant. So management is already discussed. So repeat FNA is usually considered in 2 conditions, when it is non-diagnostic, another category 3. So ultrasound guided and all can be considered. Otherwise for non-neoplastic it is just a follow-up, clinical and radiological correlation should be done. And surgery will be considered after 4A. Surgery is usually considered, that is after 4th category surgery is considered. Even ATP of undetermined significance surgery is considered, but before that core needle biopsies, open biopsies, repeat FNAs, after considering everything surgery will be planned. So this was with respect to Milan system for reporting salivary gland cytopathology, and hope this video was useful both for the pathologist as well as for the surgeons. Thank you.